We've come a long way from the 1993 International AIDS Conference, when the results of the Concord trial were published, when it was shown that early treatment or monotherapy with AZT was without any value. After that, quite a few studies have shown, of course, that it's better to treat people in advance of their getting sick or ill than differently. This study, the SMART study, of course everyone knows about it, shows that really having people in drugs, I mean in ART, are more helpful to them than not having the treatment. Inflammatory markers are associated with absence of treatment, and as we know, a large part of the disease burden, except AIDS, of these people, the HIV-infected people, come from the inflammatory action derived from the infection of HIV. Later on, we had, in 2009, we had this NA Accord study, one of the first, although it's a cohort study, showing that for, the pointer.
Oh, the pointer, you have to.
Yes, it's here, okay,
Yeah.
okay, thank you. Showing that for people with even high CD4 cell counts, it was worthwhile to treat them comparing with people without this treatment. We have the CIPRA HT001 in Haiti, showing that had to be interrupted because late treatment was associated with an unacceptable quantity of deaths or the occurrence of tuberculosis. And of course, HPTN 052 showed that treatment of index patient was able to reduce by 96% the infection in the transmission in serodiscordant couples. HPTN 52 has just published a third or a second paper. This will appear, it's already on the web, and it will appear in April, this month. This study definitely shows that treating people with CD4 cell count under 500 or 550 is better than having them without treatment or waiting until the disease gets more advanced. So I am presenting a few points in this study. Dr. Beatriz Greenstein, who is the principal investigator, allowed me these slides to present, but I have no link, no other link with the study in itself. So this is a very large controlled double-armed controlled study with people from 4 different continents. North America was here, but there were only 2 individuals or 2 couples involved, and they were discarded. This has been this is the final disposition out of more than almost 5,500 couples. In the end, 853 individuals, yes, were in follow-up after early treatment, and 848 were assigned to delayed treatment as of the last time. The baseline characteristics are here. The groups were absolutely comparable, no great difference, and this is the results comparing individuals with early treatment and individuals with delayed treatment. There is a significant effect considering any AIDS event, especially tuberculosis, and in other areas, in other points, the effect is not as visible or is not visible at all. For example, in the secondary events, non-AIDS defining events, the p-value is 0.5. There is no advantage here, nor any advantage in all deaths. Deaths were the same. However, this is the first randomized controlled trial to examine benefits of ART initiated at high levels of CD4 cell count compared to the usual, some time ago at least, of less than 250. There was certainly a trend towards a shorter time to primary clinical event, AIDS and non-AIDS defining, and delayed therapy was associated with a significantly shorter time to AIDS events and TB. I would suppose that if this study had been done in other places, not in Latin America, Asia, and Africa, perhaps this effect in tuberculosis would not be that important. But in our countries, this is certainly a major result and something that should be very well signified, very well noted. So, non-AIDS defining events were rare. The overall incidence was lower in the patients on immediate therapy, and this was driven by clinical events directly related to HIV infection, like tuberculosis, herpes virus infection, herpes zoster, Candida, and skin conditions like pruritus. Early ART significantly delayed the time to AIDS defining events and TB, and significantly decreased the incidence of clinical events. Of course, combined treatment and prevention benefits of ART support early initiation. This work is published in Lancet and is accompanied by an editorial commentary that states that this is the end of debate about antiretroviral treatment initiation. I should remind us all that this is the first and only, so far, randomized controlled trial. All the other evidence we had until now were derived from cohort studies or observational studies and not of any RCT. This slide and a few later on were lent me by Juplana. Considering what I have just said, we should certainly treat people early because of the biological plausibility, no doubt about that. There is overwhelming evidence that it increases survival. There is no immune reconstitution syndrome when we start treating them at higher levels, and there is a reduced incidence of TB. This study, published in 2011, shows that the viremia crop years predict mortality among treatment-naive HIV-infected patients initiating antiretroviral therapy. So this is one evidence that if we start treating earlier, even than 500 or 550, we may get better results. Furthermore, if we initiate treatment at lower CD4 cell counts, the rate of recovery is certainly far less, and many patients are not able to attain the same levels of CD4 cell count that other individuals will attain. However, if treatment is initiated early, started early, and the CD4 cell count is kept up over 500, the life expectancy is similar to that of the non-HIV infected. This study appeared in December 2013, shows that a 20-year-old positive adult on ART in the US or Canada is expected to live into their early 70s, a life expectancy approaching that of general population. Incidence of AIDS-defining illnesses, in particular malignancy, are higher in individuals with cell4 count was high, but lower than in individuals with higher cell4 count numbers. And importantly, the cause-specific mortality of HIV-infected individuals seems to show that the possibility of reducing the risk of non-AIDS mortality is obtainable by treating these individuals eventually. One point regarding the early initiation is what will happen, what will occur once we start ART. Cardiovascular disease is independently associated with HIV, probably accelerated by the use of some antiretroviral drugs, but probably the effect of untreated HIV is worse than the effect of drugs. Kidney disease is very important and is getting common, especially considering that there are at least 2 antiretrovirals that are deleterious to the kidney, namely tenofovir and atazanavir. But it seems that treatment prevents the development, at least, of HIV-associated nephropathy. Liver disease, although individuals with HIV, treated for HIV but not treated for hepatitis, will still have their liver disease progress. It progresses far less rapidly or completely than otherwise, than if no of the 2 infections had been treated. And probably early ART will be able to prevent some malignancies. Neurocognitive dysfunction is something that we see very little nowadays, considering, at least I see very little nowadays, considering what happened a few years ago, because ART prevents and even treats dementia. But finer, less evident cognitive dysfunction is probably still occurring. One point that I would like to stress is this. If we intend to treat, and we are having to do it, if we intend to treat the millions of people deserving and necessitating treatment in the world, we cannot rely on physicians and we cannot rely on infectious diseases specialists alone. But we must consider, for instance, this study back in 1996 that showed that for HIV people with advanced disease, the experience of the physician was very important, was a very important determinant of mortality. So it is clear that if we allow patients with HIV to get sick, we cannot task shift these people to individuals or health professionals with less experience. However, our question is still not should not be worried about starting ART too early, but we should strive to start it soon enough. And this study that was just published, median CD4 cell counts at the start of combined ART therapy remains below 200 cells per microliter in low-income countries, and is below 300 cell counts in individuals in high-income countries, showing obviously that's not a question of treating early, but rather a question of diagnosing early. What about individuals with higher CD4 cell count? It's clear for us now that treating people with around or under 500 CD4 cells is important, is mandatory, considering the HPTN 052. But if we were to expect for results for people with higher CD count than that, we will expect to the finishing of the strategic time of antiretroviral treatment, an ongoing randomized clinical trial that will only be finished by December 2014. And considering the results of HPTN 052, it's possible that no great results come from this study. Muito obrigado. Thank you very much. And once again, my thanks to the Administration.